welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for EHA. Today, we are honored to have Professor Hartmut Döhner, who is joining us to discuss the management of acute myeloid leukemia, AML, in older, unfit patients. Welcome, Professor Döhner. Professor Döhner is an internationally recognized expert in AML. He leads the Department of Internal Medicine at the University Hospital Ulm in Germany. His groundbreaking work has significantly advanced our understanding of genetic alterations in AML and has led to the development of personalized treatment strategies. In this episode, we will explore the complex landscape of AML management in older or unfit patients, a vulnerable population that represents a significant proportion of AML cases. Thank you for being with us today. To start off, can you explain, please, what are the key factors in assessing fitness for intensive chemotherapy in older AML patients?
Well, thank you. First of all, thank you for your kind introduction. There are several factors that we need to take into account. First of all, of course, it's patient age. Although patient age should not be the decisive determinant to guide therapy, it's, of course, the patient performance status, usually according to ECOG. It's one important factor, comorbidities, very important. For example, renal insufficiency, pulmonary insufficiency, cardiac failures. These are all factors influencing therapy and in particular adverse events following therapy. And importantly, cytogenetics and molecular features of the leukemic cells that are also very important in guiding therapy in these older unfit patients. And last not least, I would say it's of course also the patient. What does the patient want and his family? I think that's something very important that we always need to take into account.
So you mentioned it briefly, but how do molecular genetic profiles influence treatment decisions in unfit AML patients?
Well, regardless of fitness and age, genetics is important to establish the correct diagnosis according to the new disease classifications, according to the international consensus classification and the WHO classification. With regard to molecular treatment, currently genetics in these older unfit patients is perhaps a bit less important compared to younger fit patients. So with our current standard treatment, the combination of the BCL2 inhibitor venetoclax and a hypomethylating agent, either azacitidine and decitabine, we have a treatment that is given mutation agnostic. So it's not really focusing on a specific molecular subset of the disease. One important exception to this is IDH1 mutated AML, because now we have a very efficacious combination treatment with ivosidenib and azacitidine in this patient group. With regard to prognostication, several studies have now shown that both the 2017 and 2022 ELN risk classifications do not provide clinically meaningful outcome prediction for these patients. And therefore, recently we have developed the 2024 risk stratification specifically for patients receiving less intensive therapies. These older risk classifications have actually been developed exclusively on data from intensively treated patients. That's why it was not so surprising that these risk classifications did not really work for these older unfit patients. And this new 2024 genetic risk classification is a pure molecular genetic signature, actually consisting only of a few genes, the signaling genes, FLT3, NRAS, KRAS, and the tumor suppressor gene TP53. It's a signature that was mainly built upon data that we generated within the pivotal VIALE-A trial that evaluated the combination of venetoclax and azacitidine.
Can you discuss a bit further the role of venetoclax combinations in treating unfit AML patients?
The introduction of venetoclax in the treatment of older patients really has been a major breakthrough for these older patients. It was the pivotal VIALE-A study. So this trial evaluated the combination of azacitidine plus venetoclax versus azacitidine plus placebo. And the combination of azacitidine plus venetoclax led to a significant improvement of overall survival, 14.7 versus 9.6 months. So that was a significant improvement compared to the standard of care. An alternative is combining the BCL2 inhibitor venetoclax with low-dose cytarabine. This has been evaluated in the VIALE-A trial. And this is a combination in particular important for those countries where the HMAs, the hypomethylating agents, are not improved or are not reimbursed.
What are the current recommendations for less intensity chemotherapy regimens in older unfit AML patients?
As I already mentioned, current standard of care in I would say in most countries is the combination of the BCL2 inhibitor venetoclax with a hypermethylating agent, an HMA, either azacitidine or decitabine. An alternative is combining venetoclax with low-dose cytarabine. For some older patients, this treatment might even be too intensive. An alternative for even more unfit patients is to give HMAs as a single-agent treatment or just low-dose cytarabine. And we need to consider that that there is a proportion of patients in real-world practice who will not tolerate either of these treatments. So these patients will receive what we call best supportive care. So hydroxyurea in case of proliferation of the leukemia and transfusion support. And another very important development of the last 2-3 years is the introduction of the IDH1 inhibitor, ivosidenib. This has become also a standard of care for those patients. So these are currently the approved treatment options we have for older unfit patients.
How does the monitoring of measurable residual disease, MRD, impact prognosis and treatment strategies in unfit AML patients?
Well, so far, MRD does not have a major role in monitoring treatment in these older patients, mainly because we don't have a lot of data. But first studies using multicolor flow cytometry and quantitative PCR actually have shown that those patients who achieve MRD negativity have a better outcome, have a better overall survival compared to those who remain MRD positive. But I think before entering clinical practice, we need many more data on MRD. For example, we first need to define the right time points where MRD has to be tested in these patients, in these less intensive therapies. There will be upcoming new ELN recommendations from the MRD group, and we hope that these new recommendations will be published sometime next year.
And how have the prognosis and survival rates for older unfit AML patients changed in recent years with the introduction of new targeted therapies and less intensity chemotherapy regimens?
Well, we have achieved significant improvement. It started with the introduction of the hypermethylating agents about 15 years ago. It was only a moderate improvement in overall survival by introducing the HMAs, azacitidine and decitabine. And as I mentioned earlier, the major breakthrough came with the clinical development of the BCL2 inhibitor, venetoclax. This really led to a significant improvement of overall survival. And more recently, the development of the IDH1 inhibitor, ivosidenib, with azacitidine specifically for AML with IDH1 mutations. This has become a very efficacious treatment, and this was based on data from the pivotal AGILE study, and these data led to the approval of this combination both by FDA and the European Medicines Agency.
What emerging targeted therapies show promise for improving outcomes in older unfit AML patients further?
Yeah, there are quite a few very interesting developments. First of all, the development of the oral azacitidines, notably the oral decitabine Astex 727, which has already been approved by EMA, for the time being only as single agent, but we are expecting also the approval sometime for the combination of Astex 727 with venetoclax. And the second very important development is the introduction of the so-called triplet combinations. So combining the backbone of Ven/Aza plus additional targeted agents, for example, Ven/Aza plus FLT3 inhibitor gilteritinib, or the backbone of ivosidenib azacitidine plus venetoclax for IDH1 mutated AML. There's another interesting development. This is the development of second generation BCL2 inhibitors. So beyond venetoclax, now we have a second BCL2 inhibitor in early clinical development for AML. This is sonrotoclax. And probably one of the most promising new class of agents are the so-called menin inhibitors. These menin inhibitors are specifically developed for two molecular classes of AML, and this is AML with mutated NPM1 and AML with KMT2A rearrangements. So the first data we have from relapsed refractory AML are very encouraging, and these agents are now rapidly moving into frontline therapies in combination with standard of care regimens. So for example, Ven/Aza plus menin inhibitor for first-line treatment of AML with either NPM1 mutation or KMT2A rearrangements. So these are some of the new developments which are in phase 1 or even now starting phase 3 clinical trials.
And how do you approach treatment decision-making for unfit patients with high-risk molecular features?
Yeah, this remains actually, irrespective of age, an area of great unmet medical need. AML with high-risk molecular genetic features. So one prime example, of course, is AML with mutated TP53. Whatever we do, in terms of treatment for these patients, the median overall survival time ranges between 6 and 9 months, which of course is very short. And everything that has been tried in the past has failed. So even with the combination of venetoclax azacitidine, we can improve response rates, but these improved response rates do not translate into improved overall survival. So actually, some of the centers have become hesitant to offer these patients this combination because there's no improvement in overall survival. Some centers still do it because they think that some of these patients who achieve remission can eventually be assigned to allogeneic transplantation. So this might be an advantage of achieving remission by the combination of Ven/Aza, although by the treatment itself we do not prolong overall survival. There has been great hope in improving outcome of these patients by targeting the immune checkpoint CD47 using magrolimab. Magrolimab was the first-in-class CD47 inhibitor, but all 3 pivotal studies failed, did not improve survival, and turned out to be too toxic. So this was a major disappointing only recently for these high-risk AML, actually. Yeah.
What about CAR-T? Are they close to be developed, CAR-T cells for AML? It's been really difficult, I know.
Unfortunately not. And this is a major difference between lymphoid neoplasms and myeloid neoplasms. I mean, we have seen great success with CAR-T bispecific antibodies in lymphoid malignancies, but myeloid malignancies is lagging far behind. It's sometimes difficult to explain, but one factor is certainly identifying the right target, whether it's CD33, CD123, CLL1, FLT3, also immunocompetence. So we do not have probably enough immune competent cells, at least in the setting of active leukemia. And if I look at the results of the ongoing CAR T cell studies or studies with bispecific antibodies, they are not really very encouraging. So I do not expect that within the next 3-4 years we have any of these compounds approved by competent authority.
Thank you, Professor Döhner, for this insightful conversation and for sharing your valuable expertise with us. Thank you to all of you for listening, and stay tuned for our next episodes.